and they will talk about ongoing international treatment studies, which I think is a fairly interesting topic because we have seen a lot of basic research concerning pathophysiology and that kind of stuff, and I think it's now time to go over to more clinical trials. And so please, is it Ingrid who are going to start? The floor is yours.
Yes. But should we take some of the questions from the last session now?
Yeah, you can also include the answers to the questions, since we know that you are
because we have to leave. Do you want to tell me the questions, Justin?
Turn on your microphone, Kerstin.
I think there was one question about the saline infusion in the placebo group from the rituximab trial. And this is a question we have had many times. We know that some patients approve from having saline infusions, but then you have to give it a little more often than we do, like several times a week. We had one infusion, and then the next was 14 days, and after that it was 3 months interval between, and it was only half a liter. So it's not enough to give the placebo group effect. And that was one question. And then I think one question was about nitroglycerin, also nitroglycerin, used for angina, if that was a possible treatment for ME patients. And we know from the FMD tests that some of the patients had improvement of some cognitive feeling that they were better, but this will only last for a few minutes because it's very short lasting, this medication. So no, I don't think it's a treatment for ME patients. And the third question, I think it was something about rituximab and MS and long COVID. And I think I will touch into that when we talk about the clinical trials, and then if the person that asked that question can ask it again after the session, maybe. Okay. Ingrid Gurvin Rekeland is my name. If some of you didn't, if some of you were not here this morning, I am an oncologist at Haukeland University Hospital, and I work mostly with colorectal cancer, but I also work in the ME CFS research group at Haukeland University Hospital, together with this nice gang. Okay, so we have done clinical trials for ME CFS. We have done a few previous studies with rituximab, a small pilot study, and a small placebo-controlled study, and an open-label study with rituximab maintenance treatment. And this was very interesting data with some very good responders. So we wanted to proceed and needed a larger randomized trial. And then we conducted the RituxMe trial, a double-blind phase 3 study with rituximab and placebo with 150 patients, and this was published in 2019. This was a negative study. There were no significant differences between rituximab and the placebo group. And then, approximately at the same time, we did a cyclophosphamide trial, an open-label phase 2 study with 40 patients that had cyclophosphamide infusions. This was published in 2020. And the clinical response rate was 55%. And some of these had long-term responses, but there was no placebo group. So the response rates must be validated with caution. But now this summer we published a 6-year follow-up study from both the RituxMe and the CycloMe trial, and I will go into the data from that now in this session. And I will also talk about the small pilot trial with Daratumumab that we have done this year. that is ongoing until November 2024. So just a brief overview of these drugs. Completely different modes of actions of these two drugs. Rituximab is a monoclonal antibody that depletes the B cells that has the CD20 on their surface. That's a little bit important. And this is used in lymphoma and in autoimmune diseases. And cyclophosphamide, this is a chemotherapy. So this will affect all cells that are dividing, and it has a broad effect on all the immune system, and it's used in several malignant diseases and in some immunological diseases, and you can use it in very many different doses. First, this 6-year follow-up from the rituximab and the cyclophosphamide trial. We wanted to have the long-term data from these patients, and we wanted to know if the responders from the study were still in response and if there were any unexpected late side effects. And we wanted to compare the groups. Since we had a placebo group, we wanted to compare the three groups: the rituximab group, the cyclophosphamide group, and the saline or placebo group. The participation rate at 6 years was quite good. In the rituximab trial, it was approximately 75%, equally between placebo and rituximab, and approximately 94% participation rate in the cyclophosphamide trial. So, this is SF36 physical function, and laser pointer. And as you can see, they started up at SF36 physical function, approximately a little bit over a level over 30, where somewhere here around 90 is normal. And then we saw that the cyclophosphamide group, they increased from baseline 33 to 52 at 18 months, and then after 6 years they even increased a little bit more in the mean value to 57. But then, importantly, the responders had a mean of 67. And then the rituximab study, as you can see on the graph, they have equally between the rituximab and the placebo group, and they also increased, like I talked about in the earlier session, but they are unchanged from 18 months to 6 years. And compared to other studies, the baseline level of SF36 physical functions are quite low in both studies. Okay, so this is quite an important graph, I think. Here, as you can see, the score of at least 70 in SF36 physical function at 6 years is now reached of 44% of the cyclophosphamide group, and only 27% of the rituximab group and 20% of the placebo group. And a score of at least 90, that's normal level, SF36 physical function. It reached by 18% of the cyclophosphamide group and 9% rituximab and 7% placebo group. So the conclusion is that the patient who receives cyclophosphamide report better physical function over time. And what about worsening? A drop by 20 points in SF36 physical function is seen in 6% of the cyclophosphamide group and 10% of the rituximab group and 15% of the placebo group. So it's less tendency of worsening in the cyclophosphamide group. Okay, so if you look at this graph, it's a summary of the clinical responses in our studies of SF36 physical function. As you can see here, this is SF36 physical function, and this is time. And you can see that one of the former studies we had with rituximab had quite good responses. And then this is the cyclomid trial, and this is the rituximab trial. But this is when you look at all patients, the intention to treat group, and not divided into responders and non-responders. So if we divide the graph into responders and non-responders, you can see that still it's a very good response rate in this rituximab study we had before rituximab trial. But then you can see that the cyclomid responders are also quite good, nearly 70, and they are above the rituximab trial. So our overall assessment on this is that subgroups of ME patients have clinical benefit from rituximab or cyclophosphamide. And important in this study, they had up to 10 infusions and a higher dose of rituximab than in the rituximab study. So this might have been important. And now, after the 6-year study, we know that the effect of cyclophosphamide is long-standing. And we think that this supports the hypothesis that the immune system is involved in the disease mechanism, at least in a subset of the ME patients. So this I showed you earlier today, the hypothesis for the mechanisms in ME/CFS from our group. This is an explanatory model divided into 3 steps. First, the immune response as a trigger, and then the vascular dysregulation, and then there are a lot of compensatory adaptations. So we have used the rituximab and the cyclophosphamide in our trials, targeting CD20 positive B cells. But then the cyclophosphamide might work at this level, inhibits the development of B cells into antibody-producing plasmablasts. But now we have this ongoing study with this CD38 antibody, Daratumumab, which I mentioned. And this targets the mature, long-lived plasma cells with no CD20. If these cells are producing the autoantibodies, the patients will have no effect of rituximab. And we want to target the plasma cells to lower the levels of the immunoglobulins. Okay, so we had a pilot study, 10 patients. The response rate is promising, we think. It's well tolerated, and we have no serious adverse events. So we plan for a larger randomized trial with Daratumumab and placebo. And this is the plan for the study. We will have a run-in with only measure the activities with an armband, with steps and heart rate variability. And maybe we should include the upright position, I don't know. We have a lot of biobanking. And we have also planned for this 10-hour exertion test I talked about earlier, and the hand grip, and also the nasaline test we have included. And a lot of different fun cap, which has been mentioned today, and SF36 physical function, and the pole. Yes, so this is just a tease from the study. We have 2 responders on both sides and a non-responder in the middle. And as you can see, this is SF36 physical function, really low, 10 in the beginning, and after 48 weeks, 80. and the immunoglobulin levels, the red one, and the POL short form, it's another level from decrease from 80 to 20 approximately, and this is steps increasing. So yeah, this is approximately the same. But there are also non-responders in this pilot study. So this was it for from Bergen, and now Jonas will cover the rest.
Well, before Jonas is continuing, Kerstin has perhaps some more questions on your list to Ingrid.
Well, I think you have answered.
Yeah, I'm not sure if I answered the rituximab and MS question, but the answer is probably we don't know how it will be if you have MS and used rituximab and then have long COVID, how it will work. So yeah, I don't know if there are any new questions.
Well, okay. I think then, Jonas, you can continue the presentation.
Thank you. I think maybe we need to... Yes, now it works. Colors got set. So thank you, Ingrid, for introduction to the field of ongoing research and the implications on treatment that we are going to do in the near future also. So I'm located in Uppsala, and I have met many of you before at this occasion and other occasions, and it's a great pleasure to be back here. I also know you are probably very exhausted after a whole day of lecture, so I'll try to be brief and not go too fast, and also try to stay within time. So I hope that will manage in some way. Starting with the symptoms. You've seen this picture in so many different variants over the day and also at other meetings. But I think it's important to highlight the resemblance and similarities between the patient cohorts in post-infectious diseases. And here is ME and post-COVID, but we could have added a few other post-infectious disorders also that have very similar overlaps when it comes to symptoms. And now, when we have reached so much molecular information and knowledge about what's going on in the human body and in the patients that are suffering from these disorders, I think it's about time that we reach to the clinical trials and actually try to do something about it. And I just want to focus on a few things that we are addressing with the clinical trials we have been focusing on. So, of course, we are interested in seeing what we can do with the fatigue and post-exertional malaise. But for us, working in the brain central nervous system, brain fog is one of the targets. And we know that many patients, also when they are asked, what is the worst symptom you have? You can have pain, you can have fatigue, but the brain fog is something that actually changes your possibility to and ability to do anything, basically. And it affects your daily life quality so much. POTS, as Arthur very nicely presented today, is also on the list, of course. So orthostatic intolerance is very important and also affects your ability to move, to get out of bed, etc. So what does we not know today? Well, still we are debating what is the cause of these disorders. We know maybe what is the initiating factors in many cases, but we don't know exactly what is the pathophysiology that actually ends up with all of these symptoms that we see in our patients. And of course, what is the optimal treatment and care, and that's what we are focusing on today. So, David, my faraway cousin, maybe now on a mountaintop somewhere in Himalaya, I'm not totally sure if they reached there yet. He very nicely presented the LIFT trial. I won't go through it again with you, but just want to highlight a few things so you understand what he actually presented on the dosage, because I think that's an important thing. As you know, many patients are quite intolerant to medication. So what we are doing, we have an initial phase where we actually step slowly the dosage up till we reach a level of efficacy, but not going over that and causing side effects. So that's very important, one factor. So a pre-screening period initially. And then, as David nicely presented, it's a placebo-controlled study where we are going to give low-dose naltrexone and mestinon one by one or in combination. And of course, we hope that the combination is what is going to be successful in many patients. We also will probably already now guess that there will be non-responders, as there is in many and all studies, as Ingrid also presented. And of course, that's a bit of a failure maybe to have non-responders. On the other hand, we can learn so much from these non-responders. What makes non-responders non-responders? That could be actually the key to many of the physiological mechanisms that we are studying. It would be beautiful if we also could understand totally what is the placebo based on, because that could give us insights on what mechanisms could we trigger to actually reach better success rate when it comes to our treatments. As you heard from David, we are going to do a lot of tests. There is a lot of variable connections, shape test is non-invasive, IC-PET test, a lot of questionnaires is going to be collected. FunCap is what we really promote. Our Norwegian colleagues have presented a new questionnaire tool for us to measure functionality. And it's going to be very nice to compare with also the other studies going on in the world where they use the same questionnaire. We are also going to do Brain Vital, as Suzanne also nicely presented. And I think that's an easy task tool for everybody to try. And I think you can actually, Suzanne, correct me if I'm wrong, you can actually try it yourself at home, basically. There's a freeware, so you can actually use it just to test yourself. Have a competition in family, maybe. I don't know. It's sort of fun game. But more important also is that we are going to collect blood samples and vital parameters. And the blood samples is going to be addressed with many of the most advanced analytical tools we have for biomarker screening. So hopefully in the end of this trial, we will be able to correlate our biomarkers to physiological functions, to outcomes of the treatment, and also shape test outcomes, for instance. So this is the first in line that we have launched from the Open Medicine Foundation trial, and many more are to come, we hope. And it's about time to move on this now. I think we are reached the level of knowledge that we actually can move forward. A colleague at Harvard, Wensong Chao, and his friends, they have collected questionnaires from over 4,000 patients. It's a self-reported questionnaire, but we have tried in that collection of data figure out what is the success, what works best for patients when they self-report. And you see a list here. We're just showing the top list, but you recognize, for instance, pacing here has fairly well turned out well, increased blood volume, etc., as also Arthur presented. Important things. But even more important, and also you can see here, what symptoms do the different interventions actually correlate with, and what is actually improving when you use these different interventions. And from this list, we have a number of different trials that we are going to test, different medications, and see what we get in small placebo-controlled trials. Also very important, which I want to address specifically, is the things that actually give side effects, and I think that is and worsening in symptoms, and also very important to collect that information and have that with you when you address these things. So important to have that on your mind when you design your studies. So my specific target, personally, I'm very interested in neuroinflammation, the brain, central nervous system symptoms, and what's in our radar right now in Uppsala is the microglia activation. These cells are quite abundant, dormant cells normally when you don't have an affected or infected brain. But when you get an infection, a trauma, scar tissue formation, viral input, something like that, you get activation of the microglia cells, and they change their format, they change their shape, they also go migrating, and they also release a lot of cytokines, for instance, signal molecules to the immune system. So almost a bit scary that you have cells that are just waiting for something to happen in your central nervous system, staying still, and then suddenly by some signal induction, they start migrating around and causing good things, but also causing bad things. And what can happen if you have the bad side of it is that you could get, for instance, neuroinflammations, you get activations that actually affects your nerve cells, and you get degradation of your nerve cells and lose nerve interactions. How to monitor that? Well, there are different things. We are monitoring cerebrospinal fluid, the liquid surrounding the brain, and we are targeting inflammatory markers in that, and we can see that the majority of patients with ME, with post-COVID, with intensive care treated post-COVID patients, etc., have a significantly elevated inflammatory marker panel in their cerebrospinal fluid. But it would be so nice if we could map this with a camera instead. So we have just started to launch a study in Uppsala based on MRI, so magnetic resonance imaging, and or magnetic resonance tomography. And we were inspired by a group in Spain, this paper here, where they showed that actually with a specific type of diffusion-based MRI, you could actually target microglia cells activation, and they studied that in an animal model, but also in a few patients. So we studied this protocol very intensively, and we planned for a study that was supposed to be 20 ME patients versus 20 healthy controls using similar algorithms that they use for their MRI camera in Spain. Turned out to be, first of all, a bit difficult to translate algorithms, a computer software program basically from a camera in Spain to a camera in Sweden, based on that there are different fabrics, different manufacturers, and they don't talk to each other, unfortunately. We solved it, but by the time when we were about to launch this study, there came another paper earlier this year by Green et al. And they actually inspired us to push this study even forward to get more information out of the data. And what they showed was that they could, with a similar technique, use it for systemic inflammation measurements. And they also did an experiment in long COVID patients, which actually showed significant differences in some regions of the brain. And this picture is very complicated for you. So I just took the summary picture, which makes sense, where you see that the colored areas of the brain here is where you have significant differences between healthy controls and your long COVID patients. And it's located in regions that make sense from the symptom picture of the patient also. So based on that study, we now have a protocol that's just been approved by IRB, Etikprövningsmyndigheten, 2 weeks ago. And we are going to do MRI, we are going to do what's called the diffusion dynamic contrast enhanced MRI and diffusion-based scan from the MRI camera. Plus we are going to do functional MRI for resting state, and we have some indications that could help us to actually see some important differences. And instead of running only ME patients versus controls, we now have increased the studies. We are going to do 25 ME patients versus 25 long COVID patients versus 25 multiple sclerosis patients, MS patients, as a very important and interesting contrast group. And then healthy controls in that context. So now 100 patients instead. And in parallel, we are going to do positron emission tomography on patients, all these individuals, with a marker, TSPO marker, that is actually known to bind specifically to microglia. So we will have a positive control, and in our multiple sclerosis patients, we have that also as a very good contrast positive control group in our study. So I think this is going to be very exciting to see how what the outcome will be. Another thing that you can do with this kind of screening or scanning in these cameras is that you can actually pull out molecular features. So you can tell, not very many molecules, but a handful of molecules can tell you what cell you're looking at. So as you see here are some examples of molecules that we can get from the camera in the scan, in the spectra from the scan. And then we can actually see what molecules are specific for certain cells, like glia cells or neuron cells. So that is also going to be used in our study. So IRB is approved. That's the primary thing to get that before you start. We're now starting recruitment in October, November, and we are starting scans in December until February at Uppsala. That's the plan. Anybody interested to see how the brain is? You can sign up, you can contact us in Uppsala, but also go through Study Me. It's the protocol from Open Medicine Foundation, where we recruit on a general basis. We recruit for other studies that we are doing also, and also healthy volunteers is also very much welcome to be part of that database also as contrast groups. Finally, this is a picture I got from Alain Moreau, our colleague in Montreal. He likes these minions, exactly. So he made, well, that's supposed to be me, apparently. They have Chris Armstrong in Australia, Wensong. He likes beer. He collects beers. Everywhere he goes in the world, he buys the local beers and then tick it off in some like bird watching app, but for beers. Then we have Alain there, Alain Moreau in Montreal, Ron Davis, Stanford, David Systrom in Harvard, and Maureen Hansen in Cornell. And by that, I just want to thank you for your interest and energy that you stayed so long. And of course, thanks to everyone who helps us with the study and support from generous donors. Thank you so much.
Well, thank you very much, Jonas, for this advanced presentation concerning what is ongoing, including MRS, which I think is a good technique for visualize brain inflammation.
Yes.
So, and just a short reflection before we go on. From my point of view, when we look at all these pictures and all this type of thing, I think it's very difficult to say that ME/CFS is just wrong thinking. You should abandon these bad ideas because we have a lot of documentation that it's not just wrong way of thinking, or as an important neurologist in Sweden said, well, why care about ME/CFS? It's just mothers who have caused a disease and symptoms in their daughters. Well, now
we have to, just a comment on that. We have, of course, to be very humble. It's a complex disorder. It's a complex situation. And just to complicate things even further, and alluding to what Ingrid presented on the Rituximab study, we just got a paper accepted in molecular psychiatry where a few patients with OCD, obsessive compulsory disorder, was treated with Rituximab, and actually it worked. That's, you know, our psychiatrist colleagues are hiding. They don't want to hear this, but it actually had an effect on that. So everything goes together in some way. So it's very, very complicated.
A complicated somatic disorder with a lot of pathophysiology and a lot of symptoms and need a lot of research.